mechanism of diabetic ketoacidosis. Diabetic ketoacidosis arises because of the lack of insulin in the body. The lack of insulin and corresponding elevation of glucagon leads to increased release of glucose by the liver, a process that is normally suppressed by insulin from glycogen via glycogenolysis and also through gluconeogenesis. High glucose levels spill over into the urine, taking water and solutes such as sodium and potassium along with it in a process known as osmotic diuresis. This leads to polyuria, dehydration, and compensatory thirst and polydipsia. The absence of insulin also leads to the release of free fatty acids from adipose tissue lipolysis, which are converted through a process called beta-oxidation, again in the liver, into ketone bodies acetoacetate and hydroxybutyrate. Hydroxybutyrate can serve as an energy source in the absence of insulin-mediated glucose delivery, and is a protective mechanism in case of starvation. The ketone bodies, however, have a low pK and therefore turn the blood acidic. Metabolic acidosis. The body initially buffers the change with the bicarbonate buffering system, but this system is quickly overwhelmed and other mechanisms must work to compensate for the acidosis. One such mechanism is hyperventilation to lower the blood carbon dioxide levels, a form of compensatory respiratory alkalosis. This hyperventilation, in its extreme form, may be observed as cool-small respiration. In various situations such as infection, insulin demands rise but are not matched by the failing pancreas. Blood sugars rise, dehydration ensues, and resistance to the normal effects of insulin increases further by way of a vicious circle. As a result of the above mechanisms, the average adult with DKA has a total body water shortage of about 6 liters or 100 milliliters/kilograms, in addition to substantial shortages in sodium, potassium, chloride, phosphate, magnesium and calcium. Glucose levels usually exceed 13.8 mol/liter or 250 mg/dl. Hydroxybutyrate, despite chemically containing the carboxylic acid instead of a ketone, is the principal ketone body in diabetic ketoacidosis. DKA is common in type 1 diabetes, as this form of diabetes is associated with an absolute lack of insulin production by the islets of Langerhans. In type 2 diabetes, insulin production is present but is insufficient to meet the body's requirements as a result of end-organ insulin resistance. Usually, these amounts of insulin are sufficient to suppress ketogenesis. If DKA occurs in someone with type 2 diabetes, their condition is called ketosis-prone type 2 diabetes. The exact mechanism for this phenomenon is unclear, but there is evidence both of impaired insulin secretion and insulin action. Once the condition has been treated, insulin production resumes and often the person may be able to resume diet or tablet treatment as normally recommended in type 2 diabetes. The clinical state of DKA is associated, in addition to the above, with the release of various counter-regulatory hormones such as glucagon and adrenaline, as well as cytokines, the latter of which leads to increased markers of inflammation, even in the absence of infection. Cerebral edema, which is the most dangerous DKA complication, is probably the result of a number of factors. Some authorities suggest that it is the result from over-vigorous fluid replacement, but the complication may develop before treatment has been commenced. It is more likely in those with more severe DKA, and in the first episode of DKA. Likely factors in the development of cerebral edema are dehydration, acidosis and low carbon dioxide levels. In addition, the increased level of inflammation and coagulation may, together with these factors, lead to decreased blood flow to parts of the brain, which then swells up once fluid replacement has been commenced. The swelling of brain tissue leads to raised intracranial pressure, ultimately leading to death.